Watching news at Prime, let's take you back to one of our leading stories now, where the Treatment Action Campaign has handed over a memorandum of demands to Health Minister Dr. Aaron Motsoaledi and the Deputy President Paul Mashatile. The group is calling for those living with HIV to urgently start receiving a 6-month supply of antiretroviral drugs. South African National AIDS Council CEO is Dr. Thembisile Xulu, who joins us from East London this afternoon. Dr. Xulu, good evening to you. Thank you very much for your time. Let's start with the significant advances that have been made in the fight against HIV/AIDS in South Africa. What have we done well, if you look back to the days of AIDS denialism, and what have we gotten wrong?
Thank you, Collie, and good evening to your viewers. So certainly what we've done well is when we launched the campaign in 2010 to test about 15 million people, and we ended up testing 18 million. We've done very well in terms of raising awareness and getting people tested and getting people to know their status. So we are in the high 94s, 95s in terms of the first 95 of the 95 targets that we measure as progress. But as you know, only once somebody tests positive for HIV, they need to be initiated on treatment. We haven't done as well in terms of initiating people on treatment and keeping them on treatment. And at this moment, we have about 1.3 million people that are living with HIV but are not on treatment. And then in terms of viral suppression, we've also done significantly well for the people that are on treatment. And one of the areas that we also need to improve on is the social behavior change, because all research is showing that condom use has declined significantly in South Africa.
Dr. Xulu, I'm going to latch on to one of the elements you've mentioned, dealing with stigma. And can I challenge you on this aspect to say, if, as the minister was saying today, including the deputy president, who emphasized the point that let's search for these 1.3 million and add to the searching of the 1.3 million who are living with AIDS, but they simply have not tested themselves as to whether or not they have this virus. The reason I'm asking you this is that, would we be chasing for such people if it wasn't for the issue of stigma, or are we possibly dealing with something completely different here as to why these people don't want to know their status?
Thanks, Collie. So we actually find that, as I say, 95% of South Africans actually know their status. So the bulk of the people that are missing do know their status, but there is a particular subset of people that we know are causing us challenges. Men, for instance, in particular, based on their lack of health-seeking behavior, do not like to come to clinics. So we would have to actively search for men in places where they would be available. The second group that we are looking for are adolescent girls and young people who are being infected by older men and are not coming on treatment because they are involved in transactional sexual relations where they are dependent and unable to negotiate. And you find that a young girl is not able to freely come to a clinic based on maybe a clinic experience or the fact that she may be perceived to be too young to be engaging in sexual encounters. The third group is key populations. So LGBTQI communities, they still face a lot of stigma and therefore do not come to normal health services. That is why there has been a move to community-led monitoring and for key populations to render services for key populations. And then lastly, as mentioned, children need to be brought by their parents for them to access treatment. We now have newer formulations. And the key driver, as you say, is the issue of stigma, but there are particular groups that we need to be searching for, because men, for instance, just do not seek health behavior. Yeah. So we had the men today signing a pledge saying they are committing to seeking health and just going for checkups even when they are feeling well.
Let's talk about the 6-month antiretroviral drugs that were the rallying cry today from the Treatment Action Campaign. One, does government have the capacity to roll this out? The minister appeared to be warming up to it, except he did say that on the 15th of December, that deadline is a little too short. But if you make your assessment, do you think that this is something that government can indeed manage to do?
Absolutely, Koli. The minister was certainly guiding us appropriately in terms of the timeline for the response. But in terms of the systems of government that are required to meet 6-monthly dispensing, it's obviously a matter of pharmaceutical quantifications, making sure that we've got enough stock, making sure that the clinics have got enough storage, but making sure as well that patients are able to handle 6 months worth of medication. Therefore, there's some training that has to go into the system, but it is something that is policy according even to the WHO, because you want to avoid a situation, Koli, where people are coming to the clinic every month, missing days of work, and therefore end up not coming to the clinic and missing medication, and then end up being virally detectable and start transmitting the virus when you could give them 6 months once they are stable. So it's something that is achievable if we are given sufficient time to plan in order to be able to roll it out and scale it up.
The last element is something that I found quite interesting. Of course, it's nothing new, Dr. Xulu, but I think it was a point of emphasis and perhaps striking for me, given that I am a parent to 2 daughters. The vaccination, it's called the HPV vaccination. Please explain what it is and why it is so important for parents to take it up.
So, Tori, the HPV vaccination, HPV stands for human papillomavirus. This is the virus that causes cancer of the cervix. The cervix is the mouth or the opening that leads into the womb. And this is a cancer that is common in women that are sexually active and is caused by that virus. What we find now is that we are able to vaccinate girls as young as the age of 9 in order to prevent them from getting cancer of the cervix. Cancer of the cervix is sexually transmitted, but it doesn't necessarily show symptoms in the male partner. So the woman could end up getting cancer of the cervix without the man having any symptoms. Therefore, it's important that we get our young girls to be vaccinated. And once they are vaccinated, it obviously prevents them from getting that particular cancer. And we vaccinate them from the age as early as 9 years old. And at the moment, as Minister was saying, we've vaccinated about 4 million girls since the campaign started. And it's a campaign that is ongoing for patients that are on medical aid. They are actually able to go to pharmacies or to the clinics in their pharmacies or to their GPs to be able to access the HPV vaccine. The only stigma against this vaccine, Crowley, is that many people believe that I am also a mother of 2 daughters and they are both vaccinated. Yeah. When I have these conversations, people believe we are selling a sex vaccine. It's not a sex vaccine, it's a cancer vaccine. And that's the message that we need to keep selling, that in order to protect our girls from cancer, no girl and no woman should be dying of cancer of the cervix because we now have the HPV vaccine available.
Very, very clear indeed. Perhaps one more question linked to this topic, Dr. Xulu. Did I hear correctly when I think it was the minister, if not the deputy president, who said that for those women living with HIV, they have more chances of getting this cancer than someone who is not living with the virus? If that's the case, if I did hear correctly, what is it that these women can do to reduce those chances of getting the cancer that we're talking about?
Absolutely true, Polly. Thanks once again. So people living or women living with HIV actually progress much faster once they are infected with the human papillomavirus from just normal cellular changes to actually full-blown cancer of the cervix. So what we do advise is for people to start antiretroviral therapy early. So it is one of the AIDS defining conditions once it's stage 4. So we want a situation where women are testing early, starting treatment early so that it prevents the development or the fast evolution from a basic cancer to a full-blown cancer when your viral load is suppressed and you are actually living a healthy and normal life because the treatment of antiretroviral therapy is working. We also advocate for women living with HIV to be having their pap smears more often. So instead of once every 2 to 3 years, some of them, if their CD4s are low, we do them every 6 months, and for them to be coming then for basic checkups in order for us to be able to scan and to see if there are any changes that we can then conduct procedures to actually cure them if we detect the cancer changes early.
Final question, and it absolutely has nothing to do now with the treatment of HIV, but it does have to do with funding. Are you worried as SANAC that with the return of the President-elect of the United States, Donald Trump, to office, his approach to things is you give me something and I also give you something back? We have been big beneficiaries of funds from the United States in the fight against HIV and AIDS. Is there worry that that funding could be curtailed? If so, what is it that we are doing actively to try and mitigate against that?
I think South Africa is in a fortunate situation, Goli, in that when you look at the spread of the funding for the HIV program in particular, unlike other African countries where 80 to 90% of the HIV response is funded by donors, in South Africa, 75% of our funding comes from the government. The US government funds about 16, 17%, and then Global Fund comes in at about 5 or 6%. So really, it's a situation where we would have to look around and find money elsewhere from the fiscus. But the fiscus currently does bear the primary responsibility for our HIV response. We have currently signed the COP agreement for the next year, the country operational plan agreement with the US government in terms of the funding that they are giving us. And as much as we do expect declines, because I think globally, it is tight financially, the focus has changed. HIV is no longer a poster child. There are issues of climate change, of war, of migration, of conflict, and countries are holding back, but we are hoping for the best. But as I said, in South Africa, we are fortunate in the sense that 75% of our HIV program is already funded by the fiscus, and we are therefore in a stronger position from a sustainability perspective.
Dr. Themisile Kulu, thank you very much for your time and what has been, at least in my view, a very educational conversation. Thanks indeed for your time. CEO of the South African National AIDS Council.